afternoon. This is Dr. James Rippey. It is my pleasure to be the moderator for today's webinar. Today's webinar presenter is Dr. Ronald Kraus, and his topic is setting the record straight on cholesterol, saturated fat, and heart disease risk. I will be giving him a formal introduction in just a moment. Today's webinar is part of an ongoing series from the Conagra Food Science Institute, which has the mission of promoting dietary and related choices affecting wellness by linking evidence-based understanding with practice. Before we begin today's webinar, I would like to turn it over to Amy Continelli, who will take you through the logistics for today's webinar. Amy?
Thank you, Dr. Rippey. CEUs. A link to obtain your continuing education credit certificate will be emailed and available on this webinar's page at ConagraFoodScienceInstitute.com within 2 days. A recording of today's webinar slides and summary PowerPoint will be available to download as a PDF within 2 days at our website as well. The presenter will answer questions at the end of this webinar. Please submit questions by using the chat dialog box on your computer screen. Thank you, Dr. Rippey.
Thank you, Amy. As I indicated, today's faculty is Dr. Ronald Kraus. And I'm Dr. Rippey. I will be the moderator. I'll introduce him formally in a minute. The learning objectives for today's webinar are the following. First, summarize the effects of dietary cholesterol on lipid levels and cardiovascular disease risk. Secondly, explain the basis for current dietary recommendations for saturated fat intake. Third, describe the effects of substituting carbohydrate for fat on lipid markers of cardiovascular disease risk. It is now my pleasure to introduce my friend and colleague, Dr. Ronald Kraus. Dr. Kraus is Senior Scientist and Director of Atherosclerosis Research at Children's Hospital Oakland Research Institute, Adjunct Professor of Medicine at UCSF, and Adjunct Professor of Nutritional Sciences at UC Berkeley. He received his undergraduate and medical degrees from Harvard University with honors and served his internship and residency on the Harvard Medical Service of Boston City Hospital. Dr. Kraus is board certified in internal medicine, endocrinology, and metabolism, and is a member of the American Society for Clinical Investigation, a fellow of the American Society of Nutrition and the American Heart Association, and a distinguished fellow of the International Atherosclerosis Society. He has served on the U.S. National Cholesterol Education Program expert panel on detection, evaluation, and treatment of high blood cholesterol in adults, and was the founding chair of the AHA Council on Nutrition, Physical Activity, and Metabolism, and is a national spokesman for the AHA. In recent years, Dr. Kraus' work has focused on interactions of genes with dietary and drug treatments that affect metabolic phenotypes and cardiovascular disease risk. It is now my pleasure to introduce Dr. Ronald Kraus.
Thank you very much, Dr. Rippey, for that introduction. And let me say it's a pleasure to address this group and discuss a topic that I think is of interest to many people and one that I've been involved with for many years. And so my goal will be to try to, as the title says, set what is often a very confusing record on cholesterol, saturated fat, and heart disease risk straight, or at least try to straighten out some of the conceptions that have led over the years to our guidelines and professional recommendations that have been evolving as the science does, and it's been my privilege to be part of that science, and so I'll share that perspective with you today. I just have a few disclosures that relate to grant support, and one of them is that I have been on the cholesterol guidelines panel for several years and have been part of the process, although, as you'll see as we go along, some of my views have evolved differently from some of the guidelines that have been developed nationally, and so stay tuned for that. I'll be dividing this presentation into really two sections. The first will be to address the role of dietary cholesterol in heart disease risk, and then we'll move on to the more substantive topic of dietary saturated fat. Now, when it comes to dietary cholesterol, I'll share with you one of my experiences, as Dr. Rippey mentioned, was chairing the American Heart Association Nutrition Committee, and this was actually more than a dozen years ago now. And I learned very rapidly that the public, and I know this is not true for this audience, but certainly for the general public, there was a tremendous amount of confusion between dietary cholesterol and blood cholesterol. And this actually is exemplified on this next slide, which says the crack can be fixed. It's your cholesterol level that worries me. The doctor's talking to an egg. And so it's not the cholesterol in the egg that we're so concerned about. It's the cholesterol in the blood. I don't know if that egg has a bloodstream, but I think this is a kind of misplaced question that often came my way. And so I had to explain to people there's a lot of media interest in cholesterol, as there now is in all kinds of dietary issues. What we're talking about when we're talking about dietary effects and heart disease risk. And so it really involves several levels of evidence. The first, as illustrated on the next slide, is what is the relationship between dietary cholesterol and blood cholesterol level. And so one of my other experiences was serving a number of years ago on an Institute of Medicine panel on macronutrients, which did an extensive literature search challenging, if you will, at least testing some of the current concepts about all the macronutrients and their effect on health. And one of my specific assignments was to look at dietary cholesterol. We came up, as shown in this slide, with a sort of a meta-analysis in a way of all the studies up until that time, which looked at the intake of dietary cholesterol versus blood cholesterol. Blood cholesterol, of course, being a marker for heart disease risk. And there are two lines. One is defined diets in more controlled conditions. The other is self-selected diets in less controlled conditions. But in both cases, there's a rather gentle slope here. And you see it goes up way into the thousands. If you look in the range where most of us consume cholesterol, 200 to 300 milligrams, or even 400 milligrams per day, such as maybe the equivalent of one egg per day, that effect on blood cholesterol, though it varies among individuals, is generally pretty modest, from 0.1 to 6.5 milligrams per day, averaging maybe 1 or 2 milligrams for most people. So that kind of already raised a flag in my eye about whether we should be concerned about that magnitude of dietary cholesterol. So there was a lot of interest subsequently in looking at the data, not just in relationship to blood cholesterol, but the bottom line is, of course, whether one gets cardiovascular disease, heart attacks, strokes, and as being the major endpoints in these studies. And this, for those of you who may not be familiar with this type of analysis, this is a so-called Whisker plot. And really there's a bottom line here, literally, at the bottom of this analysis, which describes the risk associated with egg consumption as the major source of dietary cholesterol for most individuals and heart disease risk. And the bottom line is that this little white diamond overlaps a hazard ratio of 1, which means there is no significant increase in risk or decrease in risk. It just falls in that there's no effect at all by this analysis of egg consumption and heart disease risk. There was an exception, and that is patients with diabetes appear to be more susceptible to these effects. But for the non-diabetic population, there really isn't anything worth talking about. And then things are always popping. If you read the journals every week, there is something new. And this is an example of something that just came out a couple of weeks ago in the American Journal of Clinical Nutrition, which was another meta-analysis. And I'll just summarize those results because they're really pretty similar to what I just showed you. It's just an update now. 40 studies. Dietary cholesterol was not significantly associated with coronary artery disease or stroke, either ischemic, which is due to blood clots usually, or hemorrhagic stroke. But they did point out in the second two bullets something that just is going to have to be kept in mind throughout this presentation, and that is nutritional science is really difficult to do properly. If one wants large amounts of data, one has to go to populations and use statistical analyses and count on accurate information from the participants regarding what they're eating. And there's been a lot of refinement in those tools, but as shown here, the studies in this case were heterogeneous and lacked the rigor to draw conclusions. And so we still need better data. So this is an example, again, of what really should be a work in progress, although it remains to be seen whether we will have the resources to do the kinds of studies that would be necessary to really nail this down. I think the bottom line really is that there's just no evidence that dietary cholesterol itself is a significant factor for most people. And this was finally recognized after many years of advocating restricting dietary cholesterol by the U.S. Dietary Guidelines Advisory Committee this past year. And this raised, as I think you may know, some eyebrows and some interest in the public, and the media picked up on this, is that they abandoned the recommendation for limiting cholesterol intake to no more than 300 milligrams per day, because as I had discovered myself, there just wasn't any evidence to support this, and this is finally a truly evidence-based decision to back off something which is really not necessarily of relevance to most individuals. There are, of course, exceptions. There are some people whose cholesterol levels do rise and who may be at higher risk, but for the general population, which is what these guidelines are for, there's just no evidence. When you see patients, on an individual basis, one always has to make decisions that perhaps might deviate from this. You might want to take somebody with a high cholesterol level and be a little more careful, but the evidence just isn't there to support that being of overall benefit. So that will close off, until the question period at least, the issue of dietary cholesterol and heart disease risk. And so let's turn now to a somewhat more thorny and I think even more controversial topic, and that is the role of dietary saturated fats in heart disease. And again, I'll tell you that when I came on the nutrition committee and chaired it, already at that time, 12, 15 years ago, it was assumed that that issue of saturated fat and heart disease had been pretty much put to rest. Everybody knew that saturated fat caused heart disease. Ansel Keys had led the way for many years with his cross-sectional and some of his prospective epidemiologic data relating saturated fat to heart disease. But all of that's being re-examined, and I'll try to take you through how that happened and where that has left us in terms of drawing conclusions about saturated fat and heart disease risk. So the first question really is, what are saturated fats? And I think most of this audience is pretty familiar with that question. The answer to that question is that they are fatty acids where the carbon chains are fully saturated with hydrogen, as shown in the little square there at the top. That's a saturated fatty acid, but they come in many different lengths, and these different types of saturated fats are really different chemicals: lauric, myristic, palmitic, and stearic. And we won't have time today to go into all the nuances of how those may differ biochemically and nutritionally, but it's something to keep in mind as a variable that is not always considered when one talks about saturated fat as a lump entity. It's just not that simple. And of course, this is compared with unsaturated fats. We won't talk a lot about that today with lack of time. But the unsaturated fats, which have been considered more healthful, have less hydrogens in some of those double bonds. Saturated fats, of course, are found primarily in animal foods, such as dairy products and red meat, and in oils, such as coconut, palm, and kernel oil. So I think many of you are pretty much aware of that. Let's see. Rationale then for limiting saturated fat. What provides the basis for making that recommendation? And so I'll take you through the conventional logic, which is, pretty compelling in a way. That is, it's been known for many years that when substituted for other types of fat, as well as carbohydrates, saturated fats raise levels of LDL cholesterol, which is, of course, the bad cholesterol. That is more or less an unquestionably true statement. And so in the course of our discussion today, you can take it for granted that we know that's true, and I'll come back a little bit later to show you why that still may not be a sufficient criterion to judge heart disease risk. Levels of LDL are strongly linked to heart disease risk. That's also well known. There's no doubt about that. There's been from time to time people that have challenged that relationship, but for today's discussion, one can consider that to be essentially true. So the first two bullets are true. Therefore, the third bullet should follow. The conclusion should be that reducing LDL cholesterol should be able to reduce heart disease risk, and therefore we should be concerned about saturated fat. And that's where the argument begins to break down a bit, as I'll share with you in the next few minutes. Let's see. Right here, yeah. So how much saturated fat do we eat? So part of this is quantitative, right, because we're talking about a food substance that one can measure the amount of, and all our guidelines are related to how much of that we should be eating. Now, over the years, this message has penetrated in the population sufficiently such that now we've dropped saturated fat intake from used to be up to 17-18% in the bad old days, and now it's been leveling off 11%, and it's leveled off actually for the past 15 years. It seems to have reached a point where getting it much lower than that is going to take some major surgery in our dietary practices and in our food environment. And the recommendations, which have been long-standing over the years, have been to limit intake to less than 10% of calories. So in a way, you can argue that we're going from 11% to less than 10%. Is that really a big deal? Well, in terms of the cholesterol reduction, it could be. But this gives you an idea of the framework that we're talking about. And some of the arguments, as shown here, have been to go even lower, because if we got down to 11%, then why can't we get lower? The lower we get the cholesterol and the LDL cholesterol, the lower the risk. So there have been recommendations from the American Heart Association, which have been made subsequent to my involvement with them, because I would not necessarily endorse these, as you'll see. In view of the positive linear relationship between dietary saturated fat, LDL cholesterol, and CVD risk, and current U.S. intakes, the AHA now recommends a population-wide goal for saturated fat of less than 7% of energy. So that's taking it down from 11% to less than 7%, and that becomes a big deal. So those of you who are dietitians may be aware that often requires dietary counseling. It's not always easy for people to do that, which is one reason we've leveled off at 11%. And that is an important recommendation. For that reason, it's a significant one. So what's the basis for this more rigorous restriction of saturated fat? Well, the documents that have been developed for in support of the guidelines have indicated that we should be looking at studies, carefully controlled dietary studies that have varied saturated fat intake, such as the one shown here called the Delta study, in which there were 3 diets looking at saturated fat SFA. It's 15% in the control diet, 9% in sort of the American Heart Association step 1 of the more moderate restriction, and 5% at the lowest level that was tested. And that's really what the issue is. It should be going down that low. And if you look at the LDL cholesterol reduction, it does, in fact, become larger. So this has been the basis for making a recommendation to go even lower. More recently, from the American Heart Association, the American College of Cardiology, there have been guidelines for patients who are at risk. And that at-risk category includes people that have elevated LDL cholesterol or heart disease risk factors. So those are people that really may have some special reason to be more careful about their diet. I think that's something most of us would endorse. But here we go down to a recommendation that achieves 5 to 6% of calories from saturated fat. So that again is a big jump, and to reduce the percent of calories from saturated fat accordingly. So those guidelines still stand for higher risk people, and so this is kind of where that American Heart Association went. The U.S. Dietary Guidelines Advisory Committee report looked at all the data and did not change the recommendation to keep the 10% figure in place. And so we have a little bit already of evidence that these numbers are somewhat arbitrary. How does one decide whether it should be 10% or 6% or 5% for the population. What's the evidence? Well, if it's just LDL lowering, what is the evidence to support this recommendation? So I'm going to take you now on a little adventure diving in to the world of LDL, because that has been the primary basis for these dietary recommendations, is LDL lowering. So some of you may be aware that I, for many years, have been interested in LDL as a pathologic factor in heart disease, because we do know that the rationale for heart disease risk reduction, at least as it relates to lipids, is to lower LDL cholesterol. So what is our current understanding of this dietary effect? So this is where we're going to take you on the cruise through deep waters. So bear with me on this, and I'll try to take it one step at a time. Because LDL is really not a single entity. This is something that my program kind of discovered or rediscovered many years ago. LDL is actually comprised of subclasses of particles with differing cholesterol content and differing relationship to heart disease risk. So this slide illustrates four major categories of LDL particles. So again, this is a particle which contains cholesterol. It's not cholesterol itself. It contains proteins and other lipids. We focus on the cholesterol, but it's the particle that's circulating in the blood, and those particles consist of a spectrum from larger, more cholesterol-rich to the medium, to small, and very small. They get smaller and smaller. They actually get there's less cholesterol per particle as they get smaller, so they get more compact, so they're smaller and denser. And these particles, the smaller ones, are actually associated with higher heart disease risk, and there are a number of biological factors that contribute to that. I won't have time to discuss all of these in detail, but those studies that have compared the properties of larger and smaller LDL have shown that despite the fact that the smaller LDL have less cholesterol, they have more pathologic properties. And because the cholesterol level of these particles is low, you can't really infer whether somebody has more or less of these particles strictly from the total LDL cholesterol. The total LDL cholesterol is the sum of cholesterol in all these particles, and it's the distribution of whether the particles are larger or smaller in any individual is independent of the LDL cholesterol. So that's illustrated in this slide where we see a balance in which we have two individuals, hypothetical individuals, who both have an LDL cholesterol of 100 milligrams per deciliter, which would be considered these days pretty healthy. And the individual on the left, who has a predominance of larger LDL particles with more cholesterol per particle, actually takes fewer particles to reach that 100 milligram level, whereas the individual who has smaller LDL, less cholesterol, will have more particles at the same level of LDL cholesterol. And just having more particles is something that should be considered as a potential problem medically, not to speak of the fact that those particles, each of those particles themselves has more pathologic properties. So there's been a lot of evidence to support the relationship of smaller LDL particles to heart disease risk. And so for the purpose of today's discussion, the question is, what is the effect of diet on LDL particles? That's now taking the question as we previously posed it in relationship to the effect of diet on LDL cholesterol, and translating that into a more meaningful biological and pathologic framework by focusing not on the cholesterol, but on the LDL particles. So I'm going to show you the results of just one study, and I'll try to take it slow. Hope it's coming through clear at this point, because there's a lot of information on this one slide, and I'll try to take you through it one step at a time. The bottom line is really at the top of the slide. That is, it's a reduced carbohydrate in the study, taking it down fairly low, but not to Atkins type levels, 26% versus 54%, lowers small LDL particles. Whereas reducing saturated fat in the same study from 15% to 8%, sort of close to where some of these recommendations are, does not affect the small LDL particles. And here, just for documentation, is the data to support that from this study. So this is changes in LDL particles with reduced carbohydrate intake. So here's the change. And you'll see that reduced carbohydrate intake drops the small and very small LDL particles significantly. There's actually, if anything, a slight increase in the larger LDL. But the benefit on small is pretty obvious. We've seen that, and many people now have seen that time and time again. So to lower the really bad LDL, you should be concerned about the LDL, about the carbohydrate intake affecting LDL particles. And saturated fat is doing something else. So here is the saturated fat effect, which does raise some of these particles, but it's the larger LDL that go up. And so lowering saturated fat, which is recommended, would primarily reduce the larger LDL. We've shown this, and others have shown this in several other studies. So saturated fat and carbohydrate are affecting two different processes within the LDL. Carbohydrates are affecting the small LDL with no effect of saturated fat, shown here. You see the same reduction irrespective of whether you have high or low saturated fat. So carbs are bad for the bad cholesterol, the small LDL, whereas the saturated fat effect is really primarily in the larger LDL. So that observation already tells us that the diet effect on LDL is not a simple issue, and that carbohydrates should enter into the equation. And I think these studies early on began to focus a little bit on carbohydrate as being a factor that may trump saturated fat as it relates to heart disease risk. And I'll show you some data in a moment to support that. So then the real question, though, is not so now we've talked about LDL, but the real question is not what happens to LDL or LDL particles, but ultimately we want to know whether the increase in LDL cholesterol with saturated fat or the changes in LDL particles with saturated fat translate to higher CVD risk, heart disease risk. That's the bottom line. That's what we really care about. And so since the main effects of saturated fats are larger LDL, which are less strongly related to heart disease risk, we wonder whether that might not be so bad. Saturated fat increases in LDL cholesterol may not signify a proportional increase in CVD risk because these are the larger LDL particles, whereas carbohydrates, especially sugars, which influence the smaller LDL particles, may have a disproportionate effect on risk that is not reflected in the LDL cholesterol because those particles have less LDL cholesterol. So based on those questions and those concepts, we asked a few years ago, really, what is the evidence that reducing dietary saturated fat below current intake levels has beneficial health effects? And so, as always in science, what you want is data. So, show me the data. So, we found that the data really weren't out there in a very clear way. So we enlisted the help of some epidemiologists at Harvard, Frank Hu and colleagues, to help us ask what is the evidence out there that CVD risk is reduced with lower saturated fat intake. That's really what we want to know. And so we performed a meta-analysis of 21 prospective cohort trials, that is population studies where the best efforts were made to estimate dietary saturated fat intake, and then look at health outcomes, heart disease and stroke. And this meta-analysis was done according to standard procedures, and there's a lot of small print on this slide, so don't pay attention to the small print, but look on the right at this whisker plot, and don't even look at those, but just look at the conclusions, really. The relative risk for coronary heart disease associated with saturated fat was 1.07, so that was just barely above 1, and it was not significant. There's no significant increase in risk. This was not a significant increase. And for stroke, that risk actually went the other way. Not significant, but certainly not increased. And overall, it just happened that the overall risk in these studies for both heart attack and stroke, cardiovascular disease as a whole, was exactly at 1. So we reported that we could find no evidence that saturated fat per se was related to heart disease risk, And that ignited, as maybe some of you are aware, a firestorm. I had to buy a Teflon jacket and a bulletproof vest, and this generated a lot of attention, and we weren't trying to do anything other than to say where the science was and what we could say based on the science. And then about 4 years later, this was revisited by a group in Britain that did their own meta-analysis, a much more extensive one, and I won't go through the details of this because they looked at all the different fatty acids, and I won't have time to discuss that. So just look at the top line where they looked at saturated fatty acids in 20 studies, so they had a slightly different population. And here is the whisker plot. This is, again, exactly at 1. So they confirmed what we had reported, and there was some criticism of the study because there were some problems with their unsaturated fat analyses, but the saturated fat effect in heart disease risk just didn't show up. So that was really a flashpoint for the media. We really had a lot of people asking us about that, and here's a couple of articles. Time magazine had, I think, a slightly unfortunate picture and title saying something like "eat butter." That's not what we were trying to say. What we were trying to say was that the evidence just wasn't there at this point to attack saturated fat. So one would like to know, what is the evidence that reducing saturated fat will reduce risk of heart disease? That really is the point. It's not the relationship of saturated fat to heart disease. That's important, but what we really want to know is how do we reduce heart disease risk with diet, and can that be achieved by reducing saturated fat intake? So this gets into another nutritional quandary, which I'm sure most of you understand, and that is if you're changing a macronutrient, which contributes a significant number of calories to the diet, as does saturated fat, if you're going to drop saturated fat, then you've got to substitute something else. Otherwise, you're looking at a weight loss study, and that's not what this discussion is about. Certainly weight loss is beneficial, but the question is what happens with a recommendation to reduce saturated fat. And most people with that recommendation will substitute carbohydrates. However, the best evidence from clinical trials is that substituting polyunsaturated fat, that is from vegetable oils, seeds, nuts, for saturated fat reduces heart disease risk, although even that conclusion has been challenged, and I'm not going to have time to discuss the controversies around that. But I think there's a general consensus that if one eats more foods containing polyunsaturated fats and less substitutes those for foods with high saturated fat, you are adding some health benefit. But the real question is what happens when you substitute carbohydrates, because that's what's happening out there, particularly sugars and simple starches. And the data from that, as I'll show you, support the idea not only that there's no reduction in heart disease risk, but there is growing evidence that substitution may actually increase heart disease risk higher than that associated with saturated fat. And here's an analysis published, again, a few years ago by my colleague Darian Mozaffarian, who's now Dean of Nutrition at Tufts, that looked at various ways of showing benefits or risk associated with substituting polyunsaturated fats, carbohydrates, or monounsaturated fats, such as olive and canola oil, for saturated fats. And polyunsaturated fats is predicted from the lipid benefits, which they do lower LDL cholesterol. Clinical trials and observational cohort studies all point towards greater benefits. So I think most of us would support that this is a good substitution. But look what happens when you substitute carbohydrate. The lipid chain, this is just the standard lipids. If you looked at the prediction from the small LDL particle analyses I just showed you, that prediction of risk would be higher. And that is what's been seen in the observational cohort studies. There's not a lot of data from randomized clinical trials. That's why these error bars, these confidence intervals, are so wide. So it points, if anything, to an increase. Monounsaturated fats, there's just not enough data. Interestingly, although the Mediterranean diet has been studied, it hasn't really been a study of olive oil per se, and we really don't have good data to support either benefit or risk. There just isn't enough studies on monounsaturated fat. But there certainly have been unsaturated fat and carbohydrate. So here we have the high glycemic starch issue. Some of you may be aware that starches come in different degrees of digestibility. Some of them are more rapidly converted to glucose than others. Those that have a more complex structure have less what is called glycemic index. And Marianne Jacobson a few years ago showed that when you substitute high glycemic starch for saturated fat, the risk, again, from population studies, this is not from clinical trials, but it's from the same type of population data we were just looking at. As you go from lowest to highest tertiles of glycemic index substituted for saturated fat, the starches with the highest glycemic index have the highest risk. And that supports the idea that carbohydrates are doing something via their effect on sugar metabolism that there's a lot of data to support, and I won't have time to go into all of that. So where do we stand? Well, looking at all of this, a few years ago, I was part of a panel. It was an international symposium that was held in Denmark a few years ago, published in the American Journal of Clinical Nutrition. And there's a couple of conclusions from that, which I think still hold up several years later. There's no clear benefit of substituting carbohydrates for saturated fats. Maybe if it's low glycemic index or more complex, there might be some benefit. And what's not stated here is that there's growing evidence that there could actually be a higher risk if you have too much of the sugary starches or sugar itself. And there's always a question about insulin resistance and type 2 diabetes. Here again, saturated fat is not, I didn't show you the data, but there's no evidence supporting a relationship between saturated fat and diabetes risk. So that's one more thing off the table. So at this point, I'm going to pause and ask you a question related to what I plan to show in the next few slides, and that is moving from saturated fat and sort of the chemical composition of one's diet to actually what we eat, which are foods. I think one of the conclusions I hope we get from today's discussion, and I think the dietary guidelines are headed in this direction, is that we should be thinking about foods as more complex entities than just their content of various fats and carbohydrates. And so here we have which foods have been significantly associated with increased cardiovascular outcomes. Going from cheese at the top, tropical oils at the bottom, none of the above, all of the above. Here we have the answers piling in. I'm going to wait a few seconds. We've got several hundred, a lot of people out there who have opinions about this, which is good. I like that. We'll maybe get up to 1,500 or a couple of thousand. Okay, so we have a pretty good, oh boy, they're still coming in pretty fast. I don't want to leave anybody out, but we're going to have to move on. So I'm going to take this as a pretty significant subset of all of you, and we'll skip to the results. And so a third of you on the bottom thought all of these have been associated with heart disease risk. An equal number, interestingly, fascinating, felt that none of the above were associated with heart disease risk. And I'll point to one group here, 17% of you, who have said that red meat of all these has been associated with heart disease risk. And that actually is the answer. And I'll show you the reason for that on the next slide. There's actually, for all the others, I had showed you some data for eggs that were negative, so I think people probably did not pick that one. And we'll talk about some of the others. But here is the data on saturated, on red meat, not saturated fat, but red meat itself. And higher red meat in several studies now. Again, these are large population studies, 51,000 men, 100 and some thousand women from Harvard and other places. Increase in death, in this case, from heart disease, which is significantly related to the number of servings of total red meat per day. And so that has also, I think, registered in the population. There's some discussion about that. The dietary guidelines have sort of moved away from red meat. I think maybe a little too far because it's not an all or none issue. But in fact, red meat is now potentially a culprit, and particularly processed meat has been implicated even more strongly with heart disease risk. And so there was an analysis done again. This is a group led by Daria Mozaffarian, an analysis trying to distinguish now the intake of saturated fat in terms of whether it's coming primarily from meat or dairy. Remember, those are the two major food sources in the U.S. population. And so for the same level of saturated fat, let's just take some number here in the middle, such as 4 grams a day. If that's coming from meat, that risk of heart disease is higher. If it's coming from dairy, that risk is trending actually lower. And as you go out to higher intakes, that trends even lower. And these differences between the two sources of saturated fat are significant. So this points very strongly to one of the major themes I want to leave with today, and that is that it's the food source of anything we're talking about, in this case saturated fatty acids, that should really dominate the decision process, not just what we know about a chemical effect on cholesterol. However, our own lab has provided evidence that high beef intake, very high beef intake, is associated with increased levels of LDL particles. That's what's shown here. So going from 8 to 15% with a high beef diet gives you a much larger increase in LDL particles, smaller particles as well, compared with a mixed protein diet, which is protein is coming from white meat and only a smaller amount of red meat. So there may be actually a biological basis for some of that risk associated with cholesterol particles, lipoprotein particles themselves. Here's kind of the way I think about this. There's a recipe. It may be a recipe for health or disaster, but this is one which takes us towards disaster, as you'll see. If one consumes cheese, maybe that saturated fat is not associated with heart disease risk. If one consumes lean red meat, maybe that's not so bad, but that begins to add to the risk. Then if you put this in a bun where you have this high glycemic starch, maybe even sugar. There's sugar in these buns. I just looked at one yesterday, and it has 4 or 6 grams per bun. So that combination, add a little processed meat, put it all together, that's where I think we get into a recipe for disaster, because one is taking a combination of effects that individually may have small contributions to risk, and it's the overall diet that matters, and it's the overall composition of the foods we eat that matter most. So we should focus on eating healthy foods and food combinations and meal patterns, and worry less about counting grams of saturated fat. So the first part of that sentence has been endorsed by the U.S. Dietary Guidelines Committee, that we should be focusing on healthy foods and meal patterns. But they're still counting grams of saturated fat, so I think they're trying to sort of straddle the decision process. But as we showed in our analysis from a few years ago, the effects of particular foods on coronary heart disease can't be predicted solely by their content of saturated fat. It's too narrow a focus. We didn't even talk about the individual saturated fatty acids and how they may affect risk. We don't have time for that, but that's a variable that enters into this kind of chemical approach. And more importantly even, the major food sources of saturated fatty acids contain other constituents that could influence heart disease risk. And I think that may be true, for example, for red meat. It may not be the saturated, it probably isn't the saturated fat exclusively. It almost can't be. There has to be something else going on that we are not able to measure that contributes to that heightened association with risk. So there's some more issues around food and saturated fats that I will leave you with. There's data that if you compare cheese and butter with the same amount of saturated fat, the LDL cholesterol levels are lower with cheese. So cheese has something in it, maybe calcium, extra calcium, that may be helping to keep LDL lower, and you can't predict that effect just from the saturated fat content alone. And there's recent epidemiological evidence that fermented dairy products are associated with reduced risk of heart disease independent of saturated fat. So there may be something about fermentation, and many of you are aware of the microbiome in our intestine, which is responding to various probiotics and prebiotics, and there may be something in the fermented dairy products that's beneficial. And my guess, and this is just my opinion or my thoughts, is that maybe intake of red meat may be responsible for much of the risk of heart disease and even diabetes, which we haven't talked about. It's related to red meat intake, that has been attributed to saturated fat. So it really may be that the red meat problem has really been the major concern and not so much grams of saturated fat. So again, I'm going to leave you with another study that shows how active this field is. This was published July 1st, so when was that? That was a week ago. And I just pulled this out because this is literally the latest word on butter. Here's Time telling you to eat butter. So they did a study in which they gave 1 tablespoon of butter per day, and it did increase LDL cholesterol compared with a diet with olive oil or the patient's habitual diet. But they also showed, as has been shown many times, that HDL levels are increased, not quite as much, but significantly. They looked at the data on associations of butter with heart disease, like we did for eggs and meat, and they couldn't find consistent evidence of an association. So the conclusion, which I would endorse, is that a healthy diet may leave room for moderate intake of butter, that is, a tablespoon a day, maybe more, they didn't study that, in the population with normal cholesterol, but they do give the hedge, and I would agree with this, that if you're at high risk and high cholesterol, that may be a sufficient reason to limit butter intake until we have better answers. So let me conclude by summarizing what I consider are some points to consider on the saturated fat side of this discussion today. It is really not clear to what extent dietary saturated fat has effects that are directly harmful to arteries, as opposed to having a neutral permissive role. And really it's other dietary factors that have more effects. The saturated fat is there, it may be permissive, but isn't really causal. And I underline dietary because just like cholesterol, there's saturated fat in the body that is made internally, just like cholesterol is, and it's not related to dietary saturated fat as much as it is to dietary carbohydrate. So for those aficionados, I'll just give you a little pearl, and that is that high sugar intakes actually increase body saturated fat levels, and that might be harmful to tissues. But dietary saturated fat, as I showed you, doesn't seem to have that effect. So again, it's a conundrum in which the effect of a dietary nutrient is not the same as the effect of that same chemical as it's produced by the body. But the bottom line here is we should be doing good things like eating fatty fish, nuts, and other foods with polyphenols. That's what the Mediterranean diet has shown us, legumes. These are things I think you all know. This is sort of going back to basic principles. Of course, we've now learned a lot about trans fat that we should avoid, and as I hope you now will agree, from not just by many means our data, but lots of other data looking at endpoints of heart disease risk and as a function of sugar intake, starch intake, but sugar in particular, those are bad, and the LDL story is part of that. So the foods with which saturated fats are eaten do make a difference. And then I was encouraged to give you a couple of practical points as well, and these are just mine. So this is moving from a strong science base to trying to interpret a few things. What I do is I try to discourage a phobia about dietary cholesterol and saturated fat, because that is really what has arisen over the years, that these are artery clogging and people think of them as poisons. And I think what I just showed in the previous study, the one from last week, a little butter is not going to kill you. I think some of my patients have certainly come in being exceedingly worried about what is really minutia in terms of heart disease risk. Second point is that fermented dairy products, Greek yogurts and others, can be encouraged, I think, based on the evidence that's out there. And I realize I haven't reviewed that, but there is an emerging set of data to support the benefits of that on heart disease as well as diabetes. But watch out for the sugar content. Read the labels. Some of these things that are considered low fat are not what you're after, because they're just they contain tons of sugar, and that's actually the wrong thing to do. And I believe that lean meat can have a role in a healthy diet, but when you combine it with high animal fat and processed carbs, the cheeseburger, double cheeseburger approach, and then add the bacon, that's when we really get into trouble. So it's sort of a progressively bad set of combinations that we should be more worried about rather than individual components. And so I've given you a few references for some of what I discussed today. And I want to thank you for your attention, and I think we've left some time for questions.
Thank you, Dr. Krause. We have a lot of questions. This is Dr. Rippey. First of all, I'd like to just make a comment that I guess you disagree with Jimmy Buffett about cheeseburgers in paradise, or maybe it'll just get you there quicker.
Well, yeah. If you like cheeseburgers, maybe that's the way to go.
Yeah. Okay. Red wine's the only known solvent, you know.
Right.
All right. Here's the first question. What are the guidelines regarding cholesterol and also saturated fat intake for persons diagnosed with diabetes?
Well, there are diabetes guidelines that continue to endorse limiting saturated fat to less than 10% of calories. They become more focused on increasing healthy fats rather than not so much on pushing the saturated fats to these very low levels that we discussed. So they've been ahead of the curve a little bit in encouraging unsaturated foods that are high in unsaturated fats. Limiting carbohydrates. Cholesterol, I actually don't know officially what the American Diabetes Association recommends for cholesterol, but I think, as I mentioned, based on the data that are out there, it's reasonable to continue to support limiting dietary cholesterol in patients with diabetes, because that does appear to have some additional risk that may be specific to diabetic patients.
Thank you. Next question. Since choline is a limiting nutrient in cholesterol-free eggs, and given that hospital-based food service companies are using cholesterol-free eggs for nearly all patients, do you feel that the continued use of cholesterol-free products should be eliminated?
Yeah, I don't see any real strong evidence for the general population. People that do not have high cholesterol in particular, for limiting egg yolks and using cholesterol-free or yolk-free egg products. I don't see any justification for that. I will mention that there's an emerging, maybe it's too much to bring up right now, but there's an emerging line of evidence that there may be metabolic products of choline in the gut that may have adverse effects in heart disease risk. But the bottom line is that if you look at the data, as I mentioned, that are out there, egg yolk intake, except in diabetics, is not associated with higher heart disease risk. I see no reason for restricting it.
Thank you. What is your recommendation, since you disagree with the American Heart Association on fat caloric goal of less than 7%?
Well, we're at 11% as a population. That means some people are above and some people are below. I look at the patient as an individual. So I have been involved with policy decisions. I did my stint with the AHA and the Institute of Medicine. But as a practitioner, as many, I think, in the audience are, I look at the individual patient, and I don't get caught up with whether it's 11%, 10%, or 7%. I look at what I can, which is markers of heart disease risk, the cholesterol profiles, the particles that I mentioned, other risk factors, and judge that on an individual basis, because I think I don't support going much below 10% of the population. I think that's another way to answer that question, simply because it's so hard for most people to do without the risk of having higher sugar and carbohydrate intake, and I think that trade-off is in the wrong direction. So I don't like to go below 10% on a population basis.
Thank you. Next question. Is there a way to break down particle size of LDL in a lipid panel test?
There are tests, and this is one of my disclosures, because over the years I've developed several of these analytic tests, one of which is now out there, and I'll say this because I've already disclosed that we developed one of these tests. Quest Diagnostic actually offers this test as a way of analyzing all of the individual LDL fractions. It's not widely used. I don't consider it useful for screening, but I think it's helpful in making decisions about whether to be more or less aggressive based on the measuring the small particles in particular. So those tests are out there, although they're not being used yet by most physicians.
Thank you. Does type of carbohydrate, i.e. whole grains from fruits and veggies versus simple sugars, make a difference in lowering small LDL particles?
Okay, so we have pretty good data, which I didn't show on sugar. There's no question that sugar has an effect on small LDL particles, which is pretty substantial. That's probably the major component of carbohydrates that we should be concerned about. We've done some studies with a starch that's pretty resistant, a sort of a really super healthy starch. That actually raises triglyceride levels. We haven't talked about triglyceride as a risk factor. So, to the same degree as a diet that is high in simple carbohydrates. So, the results of that study did not show an effect on small LDL, however. So I think overall a diet that is restricted in simple sugars and oriented towards whole grains, because of the fiber content, really, is what the data would support.
Thank you. There are a lot of people trending toward coconut oil for health benefits. Some physicians have said they've seen their patients' cholesterol increase as a result. Can you explain that?
Okay, so I'm going to do another ad here. I'm on the editorial board of the Berkeley Wellness Letter, which some of you may be aware. It's a subscription service offered by the University of California, Berkeley, and we do pieces on topics such as this. We did one on coconut oil, and it was such a complex topic. I can't possibly give you the answer in a sentence, other than to say that there's really no evidence of any particular benefit to coconut oil. It sort of falls in the category of the other sources of saturated fat that we discussed, other than beef. It doesn't appear to be particularly bad or particularly good. That kind of is the bottom line. But you can read all about it in the Berkeley Wellness Letter.
Okay, thank you. Next question: were the red meat studies done in the context of a higher carb diet overall? Is that why there's more risk for CVD? Yeah,
that's a very good question. So the question is whether having a higher carbohydrate intake is really part of the problem in diets that are also high in red meat. Our studies have restricted carbohydrate and then used higher amounts of saturated fat, red meat, etc. So I don't have an answer to that. My suspicion is that the combination of higher carb and higher red meat may be particularly hazardous. That was sort of the cheeseburger example. But that's one of those areas that has not yet been adequately studied.
Thank you. Next question: what if the red meat is very lean? Is it just fatty red meat?
Well, red meat. Okay, so again, we're doing another NIH-funded study to try to answer that question. But what we know from what we've done so far is that if one has lean meat without saturated fat, with lower saturated fat from all sources, that doesn't appear to have any adverse effect, at least on the measurements that we use to predict cardiovascular outcomes. The epidemiological data would suggest there is a relationship, but I suspect that the lean meat component has a relatively weak relationship. It's when you start piling on saturated fat from any source, not just from red meat, and carb, that risk can start to go up. So lean red meat itself is lower on the scale of risk.
Thanks. I'm afraid this is the last question we're going to have time for. What is considered very high intake with regards to quantity of red meat per week?
Well, again, this is a kind of a subjective target. Years ago, when I came on the American Heart Association panel, the recommendation was 2 to 3 portions of lean meat per week. We've gone back and forth on that, but I'm still around that zone as being a moderately acceptable level of intake. I think having it every day or twice a day, as we studied, begins to push the limits. But 2 or 3 times a week, I think, is reasonable.
Thank you. Dr. Krause, thank you for a very interesting and thought-provoking and I think in some ways it's cutting-edge material on your webinar. I would like to again thank Dr. Krause for this and just reiterate the key points from Dr. Krause's presentation. First, based on this webinar, the participants should be able to do the following things. Number one, first, summarize the effects of dietary cholesterol on lipid levels and cardiovascular disease risk. Secondly, explain the basis for current dietary recommendations for saturated fat intake. Third, describe the effects of substituting carbohydrate for fat on lipid markers for cardiovascular disease. I would now like to turn the webinar back over to Amy Continelli, who will repeat some of the information concerning logistics related to this webinar. Amy.
Thank you, Dr. Rippey. A link to obtain your continuing education credit certificate will be emailed to you within 2 days. Today's webinar, including the certificate link, will be available to download within 2 days at our website, ConagraFoodScienceInstitute.com. And for any CCE information, please feel free to email me at acontinelli@rippeylifestyle.com. All of our recent CEU webinars archived at the Conagra Food Science Institute website will be available for you to review and to take a quiz to get your CEUs if you weren't able to join us live. Thank you, Dr. Rippey.
Thank you, Amy. This is, as I mentioned at the beginning of the webinar, part of an ongoing series from the Conagra Food Science Institute, the NutriBite webinar series. We give these webinars approximately once every 2 months. The next webinar is entitled Toward a Sustainable Food Supply, Myths and Realities. It's being delivered by attorney Jack Bobo, who is a senior advisor to the United States Department of State in Washington, D.C. That webinar will be given on September 17th of this year from 2 to 3 p.m. Eastern Daylight Time, 1 to 2 p.m. Central Daylight Time. Registration is now available by going to our website, ConagraFoodScienceInstitute.com. Now, I would like once again to thank Dr. Krause for an outstanding webinar. I'd also like to thank all of our participants for giving of your valuable time to participate in this ongoing educational opportunity. And I would like to ask you one more favor. We'd like to know how we're doing. And so when we conclude now, we would like you to stay on the line for 1 minute and complete a brief survey about today's NutriBite webinar, setting the record straight for cholesterol, saturated fat, and heart disease risk. Again, thanks to Dr. Krause, and thank you, and please stay on and take the quiz. We take these very seriously. Good afternoon.